condition where acid from the stomach goes back to your esophagus. This is caused by pressure from the abdomen, just like the stress incontinence, for this acid to go back into the chest cavity. If you have, go back to the esophagus, which burns the esophagus. If you have hiatal hernia, I will repair it during the primary procedure. Degenerative joint disease and osteoarthritis. This is wear and tear on your weight-bearing bones. Whatever injury you've had, whatever destruction of the tissues that you had, it will stay there, but the symptoms will improve because you will not put a lot of tension and pressure on the involved joints. Heart disease and coronary artery disease improves after losing weight. Gallstones. There is an increased incidence of gallstones production while you're obese. The fat is metabolized into fatty acid and cholesterol. The cholesterol is excreted through the bile. The function of the gallbladder is to concentrate the bile. The cholesterol can precipitate and develop stones, which can cause gallbladder disease. The liver can be infiltrated with a large amount of fat. When this occurs, it can produce blockage of the liver, of the hepatic ducts. Okay. If this occurs, if large amount of fat is deposited in the liver, it can produce pressure symptoms and can destroy some of the fat cells. The treatment of choice of this is weight loss. A stroke is usually related to high blood pressure. So when we control your blood pressure, the incidence of a stroke will decrease. There are cancers that are associated with obesity. Breast and uterus for women and prostate for men. The theory is that there's increased production of hormones on morbidly obese patients. These organs are what you call target organs. The cells become irritated and can transform into cancer. Colon and kidneys are for both sexes. The theory is that the fat in our diet is metabolized or excreted from our body in a toxic form. Since the function of the colon and kidney is to eliminate waste from our body, the cells can be irritated, which then is transformed into cancer. Obesity is quite costly. As you can see, after 1 year, there are only about 65% of people who started the typical diet finished it. And the average weight loss is only from 5 to 7 pounds. This shows the percentage increase in cost comparing obese to non-obese patients. As you can see, as the BMI goes higher, your overall costs also increase. Why surgery? We know that diet and exercise only works for 1 in 20 people who are morbidly obese. Majority of those that lose weight in their own will regain weight and more in 5 years. We all know now that surgery is safe and effective. We have a lot of experience. Weight loss improves your comorbidities. The benefits of surgery outweighs the risk for morbidly obese. It means that the risk of surgery now, for most people, is less than the risk of staying morbidly obese. In 1991, the National Institute of Health had a meeting, and they reviewed all the existing literatures at that time. They came out with a decision that surgery is the only way to obtain consistent permanent weight loss for morbidly obese patients. They also gave the indications for the surgery: a BMI 40 or over, or BMI 35 to 40 with significant comorbidities. And you also have to prove that you have dietary attempts which were ineffective. Who are the surgical candidates? Patients who are 35 to 39 BMI, patients with BMI of 35 to 39 with comorbidities, or 40 and above without comorbidities. You're healthy enough to undergo a major operation. You've had failed attempts at medical weight loss. Absence of drug and alcohol problems. Alcohol has a lot of calories, so it will be difficult for you to lose weight if you continue consuming a large amount of alcohol. Another problem is that if you drink mostly alcohol, then you will not have enough nutrition, and you'll become, and which may jeopardize your health due to malnutrition. No uncontrolled psychological conditions. Everybody will see a psychologist or psychiatrists. They have to be cleared by these professionals to be sure that you can handle the stress of the surgery and the changes that will happen after the surgery. As you have seen, I have a team, a group of specialists that you will see. Every specialist have to agree that you are fit for surgery. You understand the surgery and the risks. That's why you have this video. And also, I will see you in the office and answer more questions that you have. 40 pounds is the limit weight our CT scanner can handle. You must be dedicated to a lifestyle change and lifetime follow-ups. Results of bariatric surgery is weight loss, cure and improvement in your comorbidities, increase in your lifespan, improve quality of life, health. It's important to stop the progression of those comorbidities, such as hypertension and diabetes. They have a lot of complications can happen due to that, which could be life-threatening. It is hard to socialize if you don't feel good. In personal relationship, it's hard to love somebody unless you love yourself. Patients, after having the surgery, their personal life have improved and their relationship with their loved ones have improved tremendously. It should be reasonable. If you've been morbidly obese for quite some time and you're older than 25 to 30 years old, there's a big chance that you will develop an excess skin. The elasticity of the skin decreases as we get older. Some of my patients undergo cosmetic surgery to remove the excess skin. Weight loss goal, we will discuss that. While a weight loss goal is individualized. It all depends on your bone structure and also your sex. Lifestyle changes for the better. Intimacy will surely improve. And pregnancy, I would like you to wait at least 12 to 18 months after the surgery to become pregnant. And this is a lifelong commitment. Average weight loss for gastric bypass nationally is 65 to 85%. And laparoscopic adjustable banding is 45 to 50%. And laparoscopic vertical sleeve gastrectomy is 59%. This will vary depending on how you follow the instructions. You can have a better result if you follow all our advice and eat the right food and exercise. This slide shows the improvement of your comorbidities. As you could see, diabetes an improved result in 86%, hypertension 79%, sleep apnea 86 to 84%, 84 to 86%, and high cholesterol about 72%. There are three kinds of surgical approaches: restrictive, malabsorptive, and combination. Restrictive is surgery where a small pouch is created so that a small amount of food can be eaten at a time. This is represented by gastric banding and to a certain degree with sleeve gastrectomy. Sleeve gastrectomy, aside from being restrictive, has also some hormonal changes that decrease your appetite. Malabsorptive procedures is a procedure where the small intestines are rerouted so that food escapes a portion of the small bowel. This is not performed as a primary procedure now. This is done in combination with the restrictive procedure. Combination procedures is represented by gastric bypass. We create a small pouch and also bypass a short segment of the small intestines. What are the surgical options? This is a picture of the primary surgery that I perform. On the left upper corner is the lap adjustable banding. The picture in the middle is the gastric bypass, and the picture on the right bottom is the gastric sleeve. I perform most of my surgery laparoscopically. Each of these three surgeries has 5 or 6 incisions. They are almost identical on their location and size. Adjustable gastric banding is one of the restrictive procedures. It is done laparoscopically and requires implanted medical device. It has the lowest rate of complications. As you could see in the picture, there is a belt-like device that's placed around the upper part of the stomach and is connected to a tube which is also connected to a port. A saline is injected or removed from that port to decrease or increase the size of the lumen of the stomach. This is how the adjustable banding is done. The port is implanted in the fascia. After losing weight, you can feel that port under your skin. This picture shows the food going through without the banding, and here's with the band, so the food will go through slowly where the band is located. Obviously, the tighter the band is adjusted, the lesser food can go through at one time. After 6 weeks, we will do our first adjustment, wherein you will notice a change in the emptying time of the upper part of the stomach. If you are losing 1 to 2 pounds per week, you will not need an adjustment at that time. What are the risks and complications of gastric banding? Band erosion is a condition where this band can erode inside the lumen of the stomach. Usually, this does not cause any leakage. It will just manifest it by